Hello everyone and welcome back. In part 1 of the series, we tackled the first half of eligibility criteria. That was population and interventions. There we talked about pre-specification, the three levels of PICO, the lumping versus splitting decision. Now we move to the trickier half, comparators, outcomes, and study design. I said at the end of last video that outcomes are where the most reviews stumble, and I meant it. We will spend most of our time today on that. So let us keep our running example, yoga for chronic low back pain. That is the same condition, same population, but now we are deciding what to measure, what to compare against, and which study designs we will trust. So let's get into it. Here is why outcomes deserve their own video. A typical trial of yoga for low back pain might measure 15 different things. It could be pain on numerical rating scale, pain on a visual analog scale, function on oswestry, could be function on Roland Morris, or could be quality of life on SF36. And the list goes on and on. That is 15 chances for a reviewer to find a positive result if they are allowed to pick the outcome after looking at the data. Empirical research consistently shows that selective outcome reporting, that is cherry-picking the outcomes, is one of the most common flaws in published systematic reviews. Roughly 1 in 3 reviews show evidence of it. The fix is the same as everywhere else. We need to pre-specify the outcomes. Choose our outcomes before research, write them in our protocol, and stick to them. Today we will cover how to choose them well. Let us talk about comparators. There are essentially 3 types of comparators, and that's how I keep those comparators clear in my head. Number 1, placebo comparisons, where we compare our intervention against a dummy version of itself. For drugs, it is pretty straightforward. We can think of a bogus tablet or a glucose pill, but for yoga, it's hard. What is placebo for yoga? Some trials use sham yoga or attention control, gentle stretching with no breathing component, that kind of thing. Then there is control comparisons, that is usual care, waiting list, or no treatment. These are the most common comparators in non-pharmacological trials, and they answer if yoga is better than nothing. Finally, we have head-to-head comparisons that are yoga versus physiotherapy, yoga versus Pilates, and you'll notice that these are the active comparators and tend to answer a much harder question. Is yoga better than the alternatives? In our protocol, we need to decide which of these comparisons we are synthesizing. We do not have to include all 3, but we have to be explicit about which ones count. Here is something very easy to miss. Many trials of complex interventions involve a co-intervention, something that both arms receive on top of the comparisons. We are going to see trials where both groups get standard physiotherapy and one group gets yoga. Think about what that trial is actually measuring. It is measuring the added effect of yoga on top of physiotherapy. It is not measuring the effect of yoga in isolation, and that distinction really matters a lot. If yoga and physiotherapy interact, and that is true for all the complex interventions that they interact in vivo, the effect that we are going to measure here will be different from a trial where yoga is the only intervention that is being delivered. And that is not a reason to exclude these trials. It is a reason to think carefully about how we group them in our synthesis. We might choose to subgroup by whether a co-intervention is present. We might choose to fit a random effects model that allows for additional heterogeneity over a fixed effects model. What we should not do is to ignore it. When we are choosing outcomes, the question to ask is this outcome meaningful to patients? Is this outcome meaningful to doctors? Is this outcome meaningful to policymakers? Because different stakeholders care about different things. Patients usually care most about pain and function and quality of life, and that are the patient-reported outcomes. Clinicians might care about clinical events like recurrence rate or imaging findings. Health systems care about cost and resource use, days of work, opioid use, healthcare visits. And everyone on every review should care about adverse events. I want to say this clearly because it gets missed very often. If we are reviewing an intervention and our outcomes do not include potential harms, our review is incomplete. Even for something that sounds as benign, as simple as yoga, people get hurt during yoga. They actually pull their muscles, they have exacerbated disc problems, and they are susceptible to falls. If our protocol does not include adverse events as an outcome, we need to fix it before we submit. Once we have full list of relevant outcomes, we need to prioritize them. The framework that I have shared here divides outcomes into three tiers, and that's how I keep them clear in my head. Number one, they are the critical outcomes, and these are the ones that would actually drive a clinical decision. For our yoga review, pain at 3 months could be critical, function could be critical, serious adverse events could be critical. These are the outcomes that go in our abstract, that go in our summary of findings table, and that become a part of our main conclusions. Then there are important outcomes that do inform the picture, but are not make or break in terms of decision making. It could include quality of life at 6 months, it could be satisfaction on different scales. And then there's a third tier of outcomes that are not as important as the other two. These are the surrogate markers, lab values that do not translate into anything that patients feel. We can comfortably leave them out because not leaving them out could potentially dilute the review without adding any important information that is relevant to the stakeholders. As a rule of thumb, people say that no more than 7 critical and important outcomes should be included in total. More than that, and our review becomes unreadable, and readers will skim past the findings that actually matter. There are two critical issues that come up over and over. First is multiplicity. A single trial might measure pain on 3 different scales, for example, VAS, NRS, McGill. We cannot include all 3. That double counts the same patients. So what do? We pre-specify hierarchy in our protocol. If multiple pain scales are reported, we will use the VAS first, for example, then NRS, then McGill. But we need to decide before we look at any trial. The hierarchy itself doesn't have to be perfect. What matters is that we made it before the data could influence the choice. Second is the timing. The same outcome at different time points tells us different things. Short term, say the end of treatment, tells us whether the intervention works while we are doing it. Long term, for example, 6 months, 12 months after stopping, tells us whether the effect lasts. For chronic conditions, long term outcomes matter more. So we define our time windows in advance. Short, for example, we can say that short term means up to 3 months, medium term could mean 3 to 12 months, long term could mean beyond 12 months. But we need to decide what is meaningful for our condition before we start synthesizing. Now we move on to the study designs. The default for any question about whether an intervention works is randomized trials. Full stop. Randomized trials are the experimental studies where we can effectively randomize patients and balance both known and unknown confounder. And that is what makes it so powerful. It is the only design that lets us make confident causal claims about whether an intervention caused an outcome. If randomized trials exist for our question, our review must consider them. We can choose to limit inclusion to randomized trials, or we can decide to include other designs as well. But we cannot pretend that the randomized evidence does not exist if it's there. One thing is worth mentioning. Do not get distracted by labels. Double-blind randomized controlled trial sounds rigorous, but if you do not know who was blinded and how, the label tells you nothing. Focus on design features. Was the allocation sequence concealed? Were participants and outcome assessors blinded? Was follow-up complete? Those features predict bias far better than any other label. We will come back to this when we cover the risk of bias assessment. There are situations where randomized trials alone will not answer your question. And you need to consider non-randomized trials, and there is no shame in considering them. The classic case is rare or long-term harms. If you want to know whether an intervention causes a serious adverse event that occurs in 1 in 1,000 patients, you will never see it in a 200% trial. You need observational data, cohort studies, registry-based data, population-based data. The second case is interventions that cannot be randomized. Large-scale policy changes is one of the main examples. There could be surgical innovations, public health programs rolled out across the populations. We cannot run a randomized trial of a national tobacco tax, for example. The third case is when the intervention has already been deployed. Hospital-wide protocol changes that happened 5 years ago. We cannot retroactively randomize the patients who were affected. Observational evidence is the best what we have. Including non-randomized evidence in these cases is appropriate, but it comes with a cost. Heterogeneity will be greater, confounding is harder to rule out, and our conclusions will be more uncertain. But we need to be explicit in our protocol about why we are including these studies and how we are going to handle them. Before we close, I want to name the most common misconception I see with the new reviewers. It sounds like this: I'll just see what the studies are out there and decide on my criteria. It is tempting because it feels efficient. It is also a guaranteed source of bias. Even with the best of intentions, once you have seen which studies exist, you cannot unsee them, and your eligibility decisions will be shaped by what you have seen. The discipline that protects against this is the order of operations. Protocol first. You register the protocol. PICO is one of the standard registries, and registration is free. Then we run our search, then screen, in that order every time. If we find ourselves wanting to revise our criteria after seeing the studies, that is a signal. It could not necessarily be a stop sign. We need to pause. We need to document the reason for that revision and check whether the change still makes sense from the perspective of our original question, not from the perspective of the studies we happen to find. 5 takeaways from this part. Number 1, outcomes are the single biggest source of bias in published reviews. We need to specify them. Number 2, every review includes adverse events as an outcome. Everyone. I will keep saying this until it sticks. Number 3, use the critical, important, not important hierarchy to prioritize and cap your summary outcomes at 7. That's the said rule. 4, when there are multiple measures or multiple time points for the same outcome, we need to pre-specify how we are going to choose between them. And number 5, default to randomized trials, and when you decide to include non-randomized evidence, be deliberate and be explicit about why we are taking that path. That closes our 2-part lecture on eligibility criteria. The next lecture moves to searching how to actually find the studies that meet the criteria you have. If this is helping, pass it on, and I will see you in the next one.